Good morning everyone, myself Dr. Prashant, and today we are going to discuss a very important topic in pediatric orthopedics, that is supracondylar humerus fractures. To begin with this fracture, we should know about the incidence of the injury. Nearly 2/3 of elbow injury in pediatric orthopedics are supracondylar humerus fracture, and out of these, nearly 98% are extension type of supracondylar humerus fracture and only 2% are flexion type. What these types are, we will be discussing in further slides, and nearly 10% of these fractures are associated with some kind of neurovascular injury. And some authors do believe that this incidence ranges from 10 to up to 20%. So vascular injury is very common in these fractures. So this is what we have discussed. Nearly 60% of the elbow injury in pediatric orthopedics are supracondylar humerus fractures, 98% are extension type, and only 2%, that is very rare, flexion type injuries and vessel injury occur in 10% of these fractures. What is the mechanism of the injury? There are two mechanisms which are defined in literature. One is direct injury. Direct means when the child falls over the elbow, and whenever the child is falling over the elbow, the impact will cause distal fragment to go into flexion. So it causes flexion type of supracondylar humerus fracture. And another mechanism is indirect injury. Indirect injury happens when the child falls over outstretched hand, and in that case extension type of supracondylar humerus fracture happens. And what is the position of the forearm during fall, whether it is pronated or supinated, will determine whether the fragment will go posteromedially or posterolaterally. We will be discussing about these displacement shortly in subsequent slides. So this is what we have already discussed. Coming to the classification of supracondylar humerus fracture, the classification was given by Gartland, and this is most widely used. In type 1 fracture, the fracture is undisplaced and it is diagnosed by fat pad sign. Fat pad sign is radiolucency seen either anteriorly or posteriorly along the distal humerus. We will be discussing about these fat pad sign in subsequent slides. Just to remember one point, this type 1 supracondylar humerus fracture is diagnosed with the help of this fat pad sign. Type 2 fracture is the one where only one cortices of the distal humerus in supracondylar region is fractured. On the other hand, another cortex is intact, so that the distal fragment goes into some extension, so that anterior humeral line, a line along the anterior cortex of the humerus, no longer bisects the capitellum. So that this is type 2 supracondylar humerus fracture, where some angulation is present but another cortex is intact. Type 3 fracture is the one where both the cortices are broken, so that the distal fragment is completely free from the proximal fragment. And type 4 fracture is the one which is diagnosed intraoperatively. Why this is diagnosed intraoperatively? Because something which determines type 1 fracture is whether one periosteal sleeve which was left intact in type 3 fracture is broken in type 4, so that no continuity of the distal fragment with the proximal fragment at all. So this will be unstable in flexion and extension. This will be highly unstable. Type 4 supracondylar humerus fracture is the one where both the cortices are broken, and along with both the cortices, both the periosteal sleeves are also broken. But in the type 3 fracture, one periosteal sleeve is left intact, so that some stability is there and the fragment is not freely moving intraoperatively. So reduction and fixation of type 3 fracture is comparatively easier as compared to the type 4. Coming to the next slide, this is how a normal X-ray of distal humerus looks like in a pediatric age group. These are the supracondylar ridges which are seen on the X-ray. Here you have lateral condyle. In between the lateral condyle, this is the physis of the lateral condyle. Here I have drawn the medial condyle. This is the physis of the medial epicondyle. This is the olecranon fossa. Here I have drawn radial head. This is the physis of the radius head, and this is the radial neck. This is how AP view of distal humerus in a child looks. And on the lateral view, this is the distal humerus on lateral view. This region is the capitellum, and if I draw a line along the anterior aspect of the humerus, that is anterior humeral line, it is going to bisect this capitellum in anterior 2/3 and posterior 1/3. So this is the normal radiology you should keep in mind. Coming to the next slide, this is how a type 1 supracondylar humerus fracture looks like. You can see this radiolucency which is visible over the distal humerus in supracondylar region, which is suggestive of type 1 supracondylar humerus fracture, and this is what I have already defined FET-PET sign. Type 2 supracondylar humerus fracture is something which is defined by anterior humeral line. Whenever the distal fragment is lying posterior to the anterior humeral line, this is type 2 supracondylar humerus fracture. This fragment is lying posterior because the fragment has gone into extension. Coming to the type 3 supracondylar humerus fracture, where both anterior plus posterior cortices are broken and the fragment is free. And what is the difference between type 3 versus type 4? This is an intraoperative finding. Whether one periosteum sleeve is left intact or not, that will define the difference between type 3 and type 4. Type 4 will be highly unstable during the surgery. What all are the displacements we are likely to see in a supracondylar humerus fracture? Whenever we are seeing in the coronal plane, it can shift medially or laterally. So medial or lateral displacement. It can tilt medially or laterally. So another one is the medial or lateral tilt. Third one is impaction, loss of the length. In sagittal plane, again we can have anterior or posterior displacement, and we can have anterior or posterior tilt. And the last one is rotation. So we are going to have combination of these 8 displacements. Coming to the next slide, radiology part we have already discussed. Anterior humeral line no longer bisects distal humerus, that is capitellum. That also defines type 2 supracondylar humerus fracture. FET-PET sign is pathognomic for type 1 supracondylar humerus fracture. Bowman's angle is an angle which is drawn between a line drawn along lateral condyle physis, this one, and a line which is drawn along shaft of humerus, this one line. So the angle between the two, that is theta, is the Bowman angle. We can define this angle other way around also, not just by theta, but this theta 2, that is 90 minus theta. So whenever we are calculating the theta, this would be 64 to 81, and when we are calculating theta 2, this would be nearly 9 to 26. So this is how Bowman's angle is defined. And what is the purpose of calculating Bowman angle? It predicts likely occurrence of development of cubitus varus deformity. So whenever the Bowman's angle is less than 10 degree, in that case, chances of developing cubitus varus are very high. So during reduction, we should aim at achieving Bowman's angle of more than 10 degree. Whenever a child with supracondylar humerus fracture presents to us, we should always assess for the neurology. So what all nerves can be injured in supracondylar humerus fracture are either median nerve, radial nerve, or ulnar nerve. So we play this game with the child of rock, paper and scissors. Whenever child is making a rock, we are testing for median nerve. Whenever child is making scissors, we are checking for ulnar nerve. And whenever child is making a paper, what we are looking at is radial nerve. And we also ask the child to make thumbs up. Again, we are checking for radial nerve, and we ask the child to make a OK. And whenever a child is not able to make a good OK, that is weak OK sign, that is seen in anterior interosseous nerve injury. So this is how we rapidly assess for the neurology in supracondylar humerus fracture. In which type of supracondylar humerus fracture and in which displacement, which nerve will be involved, we will be discussing that shortly. Supracondylar humerus fracture is a condition which is well known for vascular injury as well as compartment syndrome. So we should always be having suspicion for compartment syndrome. There are 5 P's which are defined in the literature for compartment syndrome. That is pallor, pulselessness, paresthesia, paralysis, and pain. But these signs can be absent in a child. A child doesn't always present with these classical 5 P's. So in a child, in spite of looking for these 5 P's, we should be looking at 3 A's. These are anxious child, agitated or apprehensive child, and another one is increased need of analgesia. So this is how we diagnose compartment syndrome in a child. So classical signs, these 5 P's will be absent in a child, and 3 A's we should be looking at. And how early we should fix the fracture. So whenever a child is having pulse along with the supracondylar humerus fracture, this is not an urgency. We can fix the fracture taking our time. But whenever a child presents to us with a pink pulseless hand, pink pulseless means pulse is absent, but the hand is pink, that is perfusion is there. Although this is not an emergency, but we should be taking the child in the OT on priority. Whenever a child does present with a white pulseless hand, that is both the pulse as well as perfusion are not there, so the likelihood of vessel injury are very high. In that case, the case becomes emergency and we should be taking the child in the operation theater on priority. That is, this is a surgical emergency. Nerve injury is never an emergency. What all nerve injuries can happen in supracondylar humerus fracture? To understand that fact, we should always remember that this is the spike of the proximal fragment which injures the nerve and artery, not the spike of the distal fragment. So whenever a child presents with the posteromedial displacement of the distal fragment, definitely the proximal fragment will have posterolateral displacement, and in that case this is likely to injure radial nerve. Whenever a child presents with the posterolateral displacement of the distal fragment, the proximal fragment will go posteromedially. So this is likely to cause injury to median nerve or anterior interosseous nerve. Ulnar nerve injury, they are commoner with flexion type of supracondylar humerus, not extension. These two displacements were defined for extension type of supracondylar humerus fracture. One more condition that we should keep in mind is ulnar nerve injury is commoner iatrogenically also whenever we are inserting the medial pin, and if we are not very aware of the fact that we are not keeping the elbow in extension and we have not dissected the soft tissue around the elbow, in that case we are likely to injure the ulnar nerve iatrogenically also. Coming to the reduction, we achieve reduction whenever the posteromedial displacement is there. The reduction will be achieved with flexion with pronation. In pronation, posterolateral structures are tight so that the reduction will be held in its place until unless we put the pins to hold it. In posterolateral displacement, with flexion you have to keep the forearm in supination so that the posteromedial structures this time are tight. Sorry for this glitch. Whenever a child presents with the flexion type of the fracture, in this extension is needed for achieving the reduction. Along with, we have to push the fragment from anterior, not the posterior, unlike extension type of supracondylar fracture. So let us just erase all of this. So posteromedial fragment whenever present, we have to keep the forearm in pronation. For posterolateral fragment, you should keep it in supine and always put 2 pins from the lateral like this, and whenever we are not sure about our reduction, we can put 1 more pin from the medial side, but always keep in the mind that ulnar nerve should always be protected. So dissect the soft tissue, keep the elbow in extension, then only put this pin. Coming to the next slide. Once you have reduced and once you have put the pin, now the supracondylar humerus fracture have become stable. After that, you put the cast also. That cast should be put in mid-prone position and elbow flexion nearly 30 to 60 degree only. Never more than 90 degree. This should not be done because this impairs the blood supply and the chances of developing compartment syndrome will be very high. So never ever put this cast in more than 90 degree flexion. And how should we assess the reduction, whether the adduction is adequate or not? I have already told you, anterior humeral line which normally bisects the capitellum should again bisect it, and you should be seeing Bowman's angle. What I told, more than 10 degree it should be achieved. This is how you assess the proper reduction. Follow up, whenever you have conserved the child, you just applied above elbow cast. That is done in mainly type 1 and type 2 supracondylar humerus fracture. Then call the child at 1 week, reassess because the chances of losing the reduction are high. If in place, then again call the child at 1 to 2 weeks. This is how you follow the child. In type 3 and type 3 supracondylar fractures, you call the child at 3 weeks only and reassess with a plain radiograph. If in its place, again after 3 weeks call the child, and at 6 weeks, that is 3 plus 3, you remove the cast. This is how we follow the child. And whenever a child is presenting with pink pulseless hand or white pulseless hand, in that case, we have to monitor the child for 48 hours and we never discharge the child immediately after the surgery. That is also one thing we should keep in mind. So what all are the complications which are possible in supracondylar fracture? These are immediate complication, that is neurovascular injury, which happens at the time of fracture. Another complication is early complication, which happens within 48 hours, that is compartment syndrome. Then comes late complications. One late complication is because of compartment itself, that is VIC, Walkman's ischemic contracture. Another is a deformity we all know, that is cubitus varus, also known by the name gunstock deformity. Another one is sometimes stiff elbow. Why? Because of HO, heterotopic ossification. So these are the complications I have already told you. Now we should be discussing something about pulselessness of the hand. Why pink pulseless hand? If there is no pulse, why the hand is pink? Because the elbow is rich in anastomosis. Even if the brachial artery has gone into spasm or even if it is injured, in that case, sometimes because of the rich collaterals, child still have good perfusion, and that is what we call as pink pulseless hand. Since perfusion is there, even if the pulse is not there, this is not a surgical emergency, and this is the basis of pink pulseless hand because of the rich anastomosis around the elbow. Coming to the next slide, why this vascular injury is so common in supracondylar humerus fracture? Whenever we talk about supracondylar humerus fracture, we always keep in mind that the child is likely to have vascular injury, and we always look for vascularity, distal pulses. We always keep the compartment syndrome in mind. Why is it so common? Because of the tethering effect of supratrochlear artery. This artery keeps artery in the place, and whenever the proximal fragment goes into displacement, the artery never goes with it. So this fragment is likely to puncture the artery. So this artery is tethered with the supratrochlear artery, and the proximal fragment penetrates through the artery, causing the injury of the artery. So this is the reason why vascular injury is so common in supracondylar humerus fracture. Brachial artery is also prone to develop spasm. So this is not always the laceration or contusion of the brachial artery, but sometimes it goes into spasm also. But we should not assume it like this is a spasm until proven otherwise. So always keep in the mind that artery might be injured and act accordingly. If it is a white pulseless hand, always explore. Coming to the next slide, what are the predictors of the vascular injury? There are three predictors. One is ecchymosis in antecubital fossa. Second is puckered skin over the antecubital region. Third is open injury. These are the three predictors of very high chances of vascular injury. CT angiography routinely not done. This is just a wastage of a valuable time, the time during which we can explore and re-establish the circulation. And one thing we should be keeping in mind is median nerve injury is very common with supracondylar humerus fracture. And another complication, compartment syndrome, is also very common with supracondylar humerus fracture. Whenever a child have median nerve injury with compartment syndrome plus compartment syndrome, the pain because of compartment will be masked, and we are likely to miss this compartment syndrome. So this becomes very dangerous to the child. So always keep in the mind that compartment syndrome is a likely complication in supracondylar humerus fracture, and this can develop concomitantly with median nerve injury. So always be vigilant. Coming to the management part of a pulseless pale hand, we have to reduce the fracture under the C-arm. We have to fix it. Then we wait for 10 to 15 minutes and we assess for the return of either pulse or perfusion. If the perfusion returns, some surgeons do believe we should fix it. Then we observe the child for 48 hours for compartment syndrome or critical ischemia. We do not explore because perfusion have been established. But some surgeons do believe that even if pulse is not present, although perfusion is present, we always explore. This is second thought. The first thought was, if after reduction perfusion has returned, just observe, don't explore. And the second thought is, even if The pulse have not returned, but perfusion has returned. Explore. So both the thoughts are fine, and there are believers for both the thoughts. So, but even after the reduction, if perfusion doesn't return, then we have to explore definitely. Perfusion is something we have to establish. Always monitor for 48 hours. Don't discharge the child. So these two thoughts we have already discussed. Prophylactic fasciotomy. Some surgeons do believe that after vascular repair, we always go for prophylactic fasciotomy because chances of compartment syndrome are very high. Very, very high. In normal case, without vascular injury itself, the chances of developing compartment syndrome are very common with supracondylar humerus fracture. And if a child is presenting with supracondylar fracture with vascular injury, definitely chances of developing compartment are very, very high. Either you go for prophylactic fasciotomy. If you are not doing that, you have to be very vigilant and always look for the signs of compartment syndrome. So after repair of the vascular injury, you keep the limb at body level. So there is a dictum in orthopedics, na, limb elevation always for the swelling to subside. That should not be followed if the child is having this vascular injury. So after the repair of vascular injury, limb should not be elevated. It should be kept at the level of the body. Sympathetic blockers should be given, and we should always monitor for the skin color and SpO2. Any change in these conditions should warrant that either the child is having compartment syndrome or the child is having critical ischemia, and decision should be taken accordingly. So I will be showing this one case to you which we have operated recently. This is type 3 supracondylar humerus fracture. This child is having medial displacement, and on lateral radiograph he was having posterior displacement. So this was extension type of supracondylar humerus fracture with posterior lateral displacement. So firstly we reduced this fracture in coronal plane. This is how we reduced the fracture in coronal plane. Then we brought the forearm in flexion and pronation because this was posterior medial displacement. This is how we brought the forearm in flexion and pronation. This is how beautifully both the cortices are matching, and this is beautifully olecranon fossa which we regained again. And lateral radiograph, this I will be showing that in AP I already showed you how beautiful the reduction is, and in lateral radiograph also this teardrop developed very beautifully, and anterior humeral line again bisecting this capitellum. And coming to the fixation part, we put two lateral pins, divergent pins. Obviously we put two divergent pins, and lateral radiograph also this was well reduced. We applied above elbow cast for 6 weeks, and we removed the cast after 6 weeks, and we started range of motion exercises for the child, and he is happy with united fracture. So this is how we treat supracondylar humerus fractures. I hope you find it useful for you. Thank you.